Welcome to the Deep Dive. Today, we're diving deep into a cornerstone of plastic surgery, non-syndromic cleft palate.
Yeah.
This isn't just, a fascinating topic. It's really a core challenge. It's going to directly impact many of the patients you, as residents, will diagnose, treat, and follow throughout your entire careers.
Exactly. And our mission today really is to cut through the huge amount of literature out there.
Yeah, there's a lot.
There is. And we want to extract the truly important nuggets for your clinical practice, for surgical decision-making, patient management, and, well, yes, for those upcoming board exams, too. We're drawing from some comprehensive CME articles, continuing medical education, and also some significant long-term studies, things like Van Aalst's paper, Salyer's big 20-year experience on two-flat palatoplasty, and Wu's evidence-based medicine review, among others.
Okay, so we're going to unpack the foundational embryology, delve into the different repair techniques and their critical trade-offs, which is key. And crucially, we'll dissect outcomes and complications. Think of this as your essential roadmap to getting really well informed on this vital area.
A shortcut, hopefully.
Hopefully. So let's jump right in. Just the sheer prevalence of this challenge. What are the latest stats telling us about cleft palate incidence, and what's particularly striking about the non-syndromic cases we're focusing on today?
Well, okay, the overall incidence is roughly 1 in 2,000 live births. Pretty consistent across races. But here's the crucial point, the clinical pearl for everyone listening. While we're focusing on non-syndromic cases, almost half, nearly 50% of isolated cleft palate patients can still have an underlying syndrome.
Wow, almost half.
Yeah. So that means you always need a high index of suspicion for syndromes in your initial evaluation. Get that genetic evaluation for the patient and the family. It's critical.
Especially if there are other anomalies present.
Absolutely. Especially then. It just profoundly impacts your counseling, the management plan, everything long-term.
That's a really striking distinction, that isolated versus non-syndromic nuance. Okay, so to truly understand why these variations happen, we need to rewind a bit. Back to the foundational embryology, because the timing of these developmental disruptions seems to be everything. Can you walk us through the key stages?
Sure. Think of it in two main parts. You've got the primary palate first, that forms quite early, around week 5 to 6 of gestation.
Okay.
This gives us the nose, the lip, the prolabium, the premaxilla, basically everything anterior to that key landmark, the incisive foramen.
Got it. Anterior to the foramen. And the secondary palate, that's our main surgical focus today, right?
That's the one. It develops a bit later, so week 6 up to week 12. This is where the palatine shelves, they have to ascend and fuse.
Right.
They fuse starting from that same incisive foramen and move posteriorly all the way back to the uvula. That forms both the hard and the soft palate. And a key detail, maybe for board prep, normal hard palate fusion connecting to the vomer usually wraps up around week 9. Any disruption during these precise windows, that's when you can get a cleft.
So it's a really delicate, time-sensitive process.
Very much so.
Given that, what factors can actually disrupt it? We always hear about genetics and environmental factors. How do they really, play together?
That's where it gets really interesting, especially for patient counseling, because it's rarely just one thing.
Right, it's complex.
Exactly. Genetic predisposition often interacts with environmental factors. Take cigarette smoking.
Okay.
We know it increases cleft risk, maybe twofold. But if you combine that exposure with a specific PGF-alpha genotype.
The interaction effect.
Yeah, precisely. That risk doesn't just add up, it jumps. It goes up maybe 6-fold.
Yeah.
This interaction is the crucial nugget you need to convey when advising parents.
Wow, so it's not just a list of risks, it's like a multiplier effect. What other environmental factors should residents really be aware of for counseling?
Well, beyond smoking, we definitely counsel on alcohol. Folate supplementation is protective, that's important. Steroid use. Historically, we thought it caused a 3-fold increase, but some recent data is actually suggesting maybe less of a direct correlation. That's an important update.
Okay.
However, anticonvulsants, things like phenobarbital, phenytoin, they still show a staggering 10-fold increase in risk. That's critical to remember.
10-fold, wow.
Hypoxia, retinoids, those are also factors. And here's a kind of practical point often overlooked. Female fetuses. They have a slightly longer palatine fusion time window.
Oh, interesting.
Which might explain why we see a bit more isolated cleft palate in girls. They just have a slightly longer exposure time to any potential teratogens during that critical period.
Understanding that developmental breakdown is definitely key. Now let's shift to the result of that breakdown, the actual anatomy of a cleft palate. What's the fundamental difference? Normal palate versus one with a cleft, especially at the muscular level. And why does that functional disruption matter so much?
Great question. So in a normal palate, you've got this intact mucoperiosteal covering over the hard palate. And the soft palate acts as this beautifully coordinated velopharyngeal sphincter, 5 pairs of muscles working together.
Right.
The levator veli palatini and the tensor veli palatini are the absolute superstars here.
Okay.
But in a cleft, that levator sling is just profoundly disrupted. The muscles don't insert where they should. They often attach abnormally along the posterior edge of the hard palate.
And that directly impacts function.
Directly. It compromises the sphincter's ability to close off the nose during speech. That leads straight to what we call velopharyngeal insufficiency, or VPI. And that means speech problems, hypernasality.
And that's the obvious immediate impact, the speech. Are there other, maybe less obvious, but still really important long-term consequences of that muscle disruption?
Absolutely. And this is critical for residents to understand, that tensor veli palatini muscle. It also helps control the eustachian tube.
Ah, the ear connection.
Exactly. So when it's disrupted in a cleft, these kids often suffer from chronic otitis media ear infections. And unfortunately, that can lead to permanent hearing loss if it's not managed proactively. It's a really significant long-term issue that needs team involvement, not just focusing on the speech.
Understanding that fundamental disruption of the levator sling really underscores the surgical challenge, doesn't it?
It really does.
So how do we, as surgeons, then categorize these different presentations, for effective planning and communication? The VO classification seems like the standard.
It is the standard, yeah. And for good reason, it's simple, it's utilitarian.
Yeah.
But, beyond just categorizing, understanding these classes immediately helps guide your conversations with parents and really dictates the complexity of your surgical approach. It can even hint at whether you might need specialized flaps later.
Okay, so let's run through them quickly. VO class 1.
That's the most straightforward. An incomplete cleft just involving the soft palate.
Soft palate only. Got it. VO class 2.
Class 2 is a complete cleft of the secondary palate. So that means both the soft and the hard palate right up to the incisive foramen.
Okay, soft and hard, secondary only. Class 3.
Class 3 describes a complete unilateral cleft. So this involves the lip and the palate. Both primary and secondary palates are affected, but only on one side. In this case, one palatal shelf actually manages to fuse to the nasal septum, leaving the cleft off to one side.
Right. And VO class 4 sounds like the most expensive.
Is generally the most severe, yes. Yeah. It's a complete bilateral cleft, again involving both the lip and the palate. Here, neither palatal shelf fuses to the vomer in the middle. So you end up with a wider midline defect and an exposed vomer right down the center.
Okay, that makes sense. Now, beyond these clear-cut classifications, there's the submucous cleft. You hear it called the tricky one. What makes it so elusive, maybe harder to diagnose? And what are those key red flags residents absolutely need to look for?
That's a fantastic question, and it's a true pearl for practice. The submucous cleft is, insidious, because it's often missed initially. It might not get diagnosed until speech problems popped up, sometimes years later. So you have to look for the classic triad. Number 1. A B-feed uvula that split uvula at the back.
Okay.
Number 2, a notched posterior hard palate. You actually have to palpate, feel for that notch along the back edge of the hard palate.
Right, you have to feel for it.
You do. And number 3, the zona pellucida. This is a thin, sometimes bluish, translucent area right in the midline of the soft palate. That's where the levator muscles failed to fuse underneath the intact mucosa.
Ah, so the muscles are cleft, but the covering isn't.
Exactly. And remember, this is actually the most common type of posterior palatal cleft. So you need to be diligent about looking for that triad on every exam.
That's a great clinical pearl. So once we've diagnosed the type of cleft, the journey for these patients is obviously long-term. What does that initial crucial preoperative assessment look like? And what's the role of that multidisciplinary cleft team we hear so much about?
Oh, the team approach is absolutely non-negotiable in modern cleft care. Right after birth, identifying any associated syndromes, any other health issues is paramount. And your team, it's extensive, surgeons obviously, ENTs, ear, nose, and throat specialists, speech pathologists are crucial. Dentists, orthodontists, psychologists, social workers, geneticists, pediatricians. Everyone plays a role.
It takes a village, really.
It truly does. And for residents, this means understanding you're a part of this dental picture. Knowing each specialty's role, knowing when to refer is key. Early on, feeding issues are often the primary concern.
Right.
So you'll counsel parents on things like easy flow nipples, keeping the baby upright during feeding. Sometimes, in severe cases, you might need temporary nasal or even gastric feeding tubes.
Yep.
And then it's about regular, usually yearly, follow-up with the full team. That's the standard for long-term success, catching any developing issues early, whether it's speech, dental, hearing, or psychosocial adjustment.
It's clear that team effort is absolutely essential, the patient's entire life. Now, shifting focus to the operating room. What are the overarching goals when we do a palatoplasty? It can't just be about closing the hole, can it?
No, absolutely not. The goals are quite clear, but achieving all of them at the same time, that's the real art of cleft surgery. We aim for, 1, complete intact closure, watertight.
True.
2, meticulous restoration of the velopharyngeal sphincter. That muscle function is key.
Right.
3, avoiding fistulas, those little holes that can form later. And 4, and this is crucial, preserving maxillofacial growth as much as possible.
Okay, so closer, function, no fistulas, and growth.
Exactly. And that fundamental 3-layer closure, nasal mucosa, then the muscle layer, then the oral mucosa, it's paramount. If you compromise any one of those layers, even slightly, your risk of complications goes way up.
How do you ensure each layer is robust?
Well, for the nasal layer, you might use separate flaps based on the palate shelves, or sometimes vomer flaps from the septum. For the muscle, those abnormal attachments must be released, dissected free, and then reoriented transversely to create that functional sling we talked about.
Right, recreating the sling.
And the oral mucosa needs a tension-free closure. That often means making lateral releasing incisions and carefully releasing the greater palatine neurovascular bundles, the pedicles, to allow the flaps to move easily to the midline without tension. Every single step matters for long-term success.
The evolution of the soft palate repair itself is fascinating, constantly refining how we handle that muscle sling. Koreans' intravelar veloplasty back in '69 really started focusing on restoring the sling.
It did.
But the early studies showed kind of mixed results compared to simpler techniques. How has that initial idea evolved into what we do now?
Yeah, it really highlights this ongoing, you could say, philosophical debate in our field. Koreans definitely laid the groundwork. But the newer approaches, things like radical intravelar veloplasty, they emphasize a much more aggressive separation of the levator muscle from its abnormal attachments to the tensor muscle and the hard palate.
More aggressive dissection.
More aggressive, more complete dissection, sometimes even involving tensor tenotomy or transection to allow for much better retropositioning, pulling that muscle sling further back where it belongs. Surgeons like Summerlad, for instance, even use an operating microscope for this.
Wow.
The idea is the more anatomically precise you are in reconstructing that sling, the better the functional speech outcome should be.
Makes sense. And then there's the Furlow double opposing Z-plasty. That seems really popular, a go-to for many surgeons.
Yeah.
That makes it so appealing.
The Furlow is, well, it's an elegant technique. It uses 2 reverse Z-plasties, one on the oral side, one on the nasal side. This does 2 things simultaneously. It lengthens the palate, which is often needed, and it rearranges the levator muscles into a more anatomical, functional sling.
So length and muscle repositioning.
Exactly. And studies, mostly retrospective, have shown it leads to reduced hypernasality and generally improved speech outcomes. Now, as the great Dr. Millard pointed out, a potential trade-off is that it can sometimes tighten the velum a bit in the transverse direction side to side. So you gain length, but maybe slightly alter the width. It's always, a balance.
And we're seeing even more advanced techniques pushing the boundaries, like the Wu component separation palatoplasty. What makes that particular approach stand out? What's the philosophy there?
Yeah, this is a great example of how techniques keep evolving, always pushing for more physiologic solutions. Wu's method involves a really radical separation of the levator muscle, dissecting it all the way back to its origin on the skull base.
All the way back.
All the way back. Then meticulously overlapping and tightening that levator sling, followed by a single Z-plasty on the oral side. The idea, supported by some computational models, is that this maximizes velopharyngeal closure potential. It really emphasizes achieving a more natural, physiologic solution to VPI right from the start, hopefully reducing the need for secondary procedures like pharyngeal flaps later on. For residents, this really highlights a growing trend: maximize primary muscle function.
Okay, so that covers the intricate work on the soft palate muscles. Now for the hard palate repair, we've got those different mucoperiosteal flap variations. What are the main concerns driving our choices there, especially thinking about long-term outcomes like facial growth?
That's absolutely the crux of hard palate repair, balancing getting it closed reliably with preserving future growth. So first, you have the von Langenbeck technique.
Okay.
This involves making those lateral relaxing incisions, creating bipedicled mucoperiosteal flaps, meaning they stay attached both front and back, preserving both the greater palatine and the incisive pedicles. It works well for incomplete secondary palate clefts, though too, and crucially, it minimizes the amount of denuded bone left exposed. That's thought to be better for long-term facial growth.
Okay, minimal exposed bone. Then there's the Vo-Wardil-Kilner, the VY pushback. This one often comes with a bit of controversy, right?
It absolutely does.
Yeah.
Historically, and even now, there's debate. This technique aims to gain palatal length. You divide the anterior attachment, the superior pedicle, and push the flaps backward, closing it in a VY fashion.
So it lengthens the palate.
It does, but the trade-off is that it denudes, or leaves bare, a significant area of bone on the anterior hard palate.
And that's the concern for growth.
That's the big concern. Historically, it's been implicated in inhibiting midfacial growth. The evidence is still debated, with conflicting study results, but many surgeons are cautious. They might prefer the von Langenbeck because of this growth concern. As a resident, you absolutely need to know about this historical controversy and its potential implications when you're choosing a technique.
Definitely something to weigh. And for the more extensive, complete clefts, the class 3s and 4Vs, the two-flap palatoplasty seems to be a real workhorse. What makes it so effective for those challenging cases?
The Bardach variation of the two-flap palatoplasty is indeed a workhorse, especially for those complete unilateral or bilateral clefts involving both the primary and secondary palates.
Okay.
It's designed specifically to use the entire oral mucosa of the hard palate on each side as large flaps. This gives you maximal tissue to bring to the midline and close the defect, which is often quite wide in these cases.
Makes sense, using all available tissue.
Exactly. And Salyer's 20-year experience with this technique, with his own modifications, really highlights the nuances. He emphasized creating that functional muscle sling, the dissection, the retropositioning.
Right.
He found consistently good speech outcomes with it, reporting an overall secondary VPI rate around 8.9%. He always stressed that creating that sling wasn't just a technical step, it was almost an art. Every millimeter of dissection and positioning really impacts that VPI outcome years later.
Salyer's work also mentions using the vomer flap as a key tool, especially in wider clefts. But he also notes that using it might slightly increase fistula rates. That feels like a real surgical dilemma. How do you weigh that trade-off better VPI versus maybe a slightly higher fistula risk?
It is a genuine surgical dilemma, yeah. And a great point for residents to think about. The vomer flap is often critical, especially for those wide bilateral clefts where oral tissue is just really scarce. You use flaps of the mucosa covering the vomer bone, the septum, to close the nasal layer, often combined with a two-flap on the oral side, creating a sort of four-flap closure.
Okay.
Salyer specifically used posterior vomer flaps. His rationale was they help recreate the posterior choanae, the back opening of the nose, and critically, they help tether the soft palate, the velum, into a more upward and backward, more functional position.
Positioning the velum better.
He believed this contributed significantly to better VPI closure. And for him, yes, that improved VPI outcome outweighed the slight acknowledged increase in fistula rates. It was a trade-off he found acceptable for the patient's overall speech function. But it's something each surgeon has to weigh.
That brings us nicely to surgical decision-making. This is where residents really start putting it all together. Let's walk through some common scenarios. For a submucous cleft palate where you've confirmed VPI is present, what's your primary approach?
Okay, submucous cleft with confirmed VPI. Your first thought process should be about improving that underlying levator sling function. You might consider a pharyngeal flap, though, that's generally seen as less physiologic.
Right.
More commonly, especially in younger patients or those with a smaller velopharyngeal gap on imaging, a Furlow Z-plasty is a great option.
Because it lengthens and reconstructs the muscle.
Exactly. It offers that dual benefit.
Okay. What about a straightforward Vauclassi cleft? Just the soft palate involved.
For a soft palate-only cleft, the primary goal is always restoring that VPI competence, reorganizing the muscle. So, either an intravelar veloplasty focusing just on the muscle dissection and repositioning, or a Furlow repair would be the most common and effective methods. The choice often comes down to surgeon preference and the specific anatomy of the palate.
Got it. Now, stepping up in complexity, Vauclass 2, that's a complete cleft of the soft and hard palate. Back to the incisive foramen. More hard palate involvement here.
Right. So here you have to address both components. For the hard palate part, you have choices. the von Langenbeck, the Voorwaardeel-Kilner, the VY pushback, or a two-flap palatoplasty.
Okay.
And then that hard palate repair needs to be combined with a soft palate repair again, usually either an intravelar veloplasty or a furlow. Surgeon preference definitely plays a big role here.
But you need to remember the growth concerns with the VY.
Absolutely. You must keep those potential long-term growth implications of the VY pushback in mind during your decision-making. You're always weighing immediate closure against potential future facial development issues.
Okay. Finally, the most complex cases, VO Class 3 and 4, the complete clefts involving both the lip and palate. These must require the most comprehensive approach, right?
They generally do, yes. These typically require a two-flap palatoplasty for the hard palate, simply because of the extent of the tissue defect. This is often combined with lip repair, usually done in stages. And specifically for the bilateral clefts, the VO Class 2, that vomer flap often becomes almost essential for getting a robust nasal mucosal closure, just because the defect is so wide and you have less oral mucosa available relative to the gap.
Right, tissue scarcity.
Exactly. And then, as always, the soft palate component needs meticulous management, usually with either a furlow or an intravelar veloplasty to properly recreate that critical muscle sling. It's definitely a multi-stage, comprehensive reconstruction for these kids.
Okay, moving beyond how we do it, let's talk about when. This is such a classic dilemma in cleft care, isn't it? Early repair for speech development versus maybe delaying repair to preserve maxillofacial growth.
Now,
What's the current thinking? Where has the field settled, generally?
yeah, this is a debate that has swung back and forth over the decades. But the trend, certainly in the U.S., is definitively moving towards repair before 1 year of age.
Before one.
Yeah, typically in the 9 to 12-month window. It's seen as a pragmatic compromise.
Why that timing?
The main goal is to achieve primary closure before significant speech development really kicks in, which usually happens after that 12-month mark. The idea is to give the palate structure before the brain learns compensatory speech patterns.
Makes sense. What about two-stage repairs?
A two-stage approach, like repairing the soft palate early, maybe 3-6 months, and then the hard palate later, like 15-18 months, has been proposed and is practiced in some centers, particularly in Europe.
But not as common here.
Not as common in the U.S., no. There are persistent concerns about potentially poorer speech outcomes if you delay closing the hard palate that long. So one-stage repair is still predominantly practiced here.
Okay. Any exceptions?
Sure. For certain syndromic cases, like Pierre-Robin sequence, where there are significant airway issues.
Right, the small jaw.
Exactly. You might absolutely need to delay palate surgery to manage those critical airway problems first. Safety first. And Salyer, for instance, with his modified two-flap, he aimed for an average age of about 8.6 months. But he always noted that it wasn't just chronologic age. The infant size and weight, their overall health, are also important factors in deciding the optimal timing.
Got it. Now, even with the most meticulous surgery, complications can happen. Fistulas are a common concern and pretty frustrating after palate repair. What are the key factors, technique, patient characteristics that really predispose someone to getting a fistula, and how do we try to mitigate that risk?
That's a crucial question for any resident starting out. Fistula rates. They vary wildly in the literature. You see numbers from as high as 50% in some older series down to maybe 3 or 4% with modern techniques and experienced hands.
Big range.
Huge range. The factors are definitely multifactorial. Surgeon experience is a big one, honestly. The specific repair type might play a role. Some studies suggest the Voorwaardeel-Kilner might have slightly higher rates than von Langenbeck or Furlow. And cleft size matters. Wider clefts, bilateral clefts, or clefts that involve the primary palate too, they generally have higher rates just because closure is more challenging.
Where do they usually occur?
Most hard palate fistulas, something like 87%, occur right at the junction of the hard and soft palate, just behind the alveolus.
Ah, that junction point.
Yeah. Salyer, in his big series, reported a 10% fistula rate overall, and he openly acknowledged that his use of the posterior vomer flap, while he felt it really helped VPI, might contribute slightly to that rate.
So how do we prevent them?
Mitigation really comes down to meticulous, tension-free, 3-layer closure every single time. Careful tissue handling, ensuring good blood supply, precise approximation of layers, that's the best prevention.
Makes sense. Beyond fistulas, hypernasal speech VPI needing secondary surgery is a really significant long-term outcome. What kind of rates should we expect, and how much can the surgical technique itself really influence whether a child needs more surgery for speech later?
Yeah, VPI requiring secondary surgery generally ranges from 10 to 30% across different centers and techniques, so it's definitely a significant possibility.
And technique matters here.
Absolutely. Surgical technique, specifically that meticulous reconstruction of the levator veli palatini muscle sling, is critical for functional speech. Techniques like radical intravelar veloplasty and the Furlow double opposing Z-plasty have consistently shown improved speech outcomes in many series, with VPI rates reported as low as 4 to 8% sometimes.
That's a big improvement from 30%.
It is. Salyer's modified 2-flap achieved that 8.9% overall rate, and impressively, it dropped down to 6.4% in his second decade of practice. That really shows the impact of experience and continuous refinement of technique.
Are there other factors predicting speech outcomes?
Yes, some factors beyond just the surgery seem predictive. Things like male sex, having a shorter palate length to begin with, a larger initial cleft width, and even the individual surgeon's experience level can predict poorer speech outcomes.
And timing again.
In timing, yes. Early repair, definitely before 18 months, and ideally before 12 months, has been pretty consistently shown to result in better speech outcomes overall, particularly fewer of those problematic compensatory misarticulations that kids develop when the structure isn't there early on.
We've mentioned maxillofacial growth several times now. We know maxillary deficiency, that mid-face flatness, is kind of an inherent part of cleft deformities, but the surgery itself is often implicated in making it worse. How do we try to disentangle the inherent issue from the potential surgical impact? It seems tricky.
It is tricky, and it's a complex, ongoing debate in the field. There's definitely an inherent hypoplasia with clefts. The maxilla is simply programmed to be somewhat underdeveloped from the start.
Okay.
The challenge is figuring out how much surgical scarring, particularly from the lip repair and the palate repair, and some studies suggest the lip repair might actually have a greater negative effect on forward growth than the palate repair.
Oh, interesting.
How much that scarring inhibits growth versus just the underlying dysmorphogenesis of the cleft itself. While some of those older techniques, like the VY pushback that denuded large areas of bone, were definitely implicated more heavily.
Right.
Newer techniques, like the 2-flap palatoplasty, really aim to minimize exposed bone for this very reason. But honestly, this is precisely why excellent long-term orthodontic care is absolutely integral to management. It's about working with and optimizing whatever growth potential exists.
Okay. Another area getting more attention recently is obstructive sleep apnea, OSA, in cleft patients. How common is it, and what are the implications for residents looking after these patients long-term?
Yeah, OSA is a really important comorbidity, and we are paying more attention to it, thankfully. It's particularly prevalent in syndromic patients or kids with Pierotin sequence because of the jaw issues. But studies show a significant incidence even in non-syndromic cleft patients. And identifying OSA before surgery can actually help predict who might have postoperative respiratory distress or airway problems.
So screening is important.
Very important. It means diligent screening for obstructive symptoms, snoring, pauses in breathing, daytime sleepiness throughout their long-term care is crucial. As a resident, you need to be aware of this risk, ask the right questions, and integrate it into your assessment, especially if you're considering secondary procedures like pharyngeal flaps that might further narrow the airway.
Good point. Finally, let's touch on perioperative management. Good analgesia, good pain control is obviously critical for recovery and minimizing distress in these young kids. What are the best practices now for managing pain effectively but safely?
Excellent question. Because effective analgesia isn't just about comfort. It really helps with recovery, reduces complications like feeding difficulties or airway issues.
Right.
Maxillary nerve blocks done carefully with longer-acting local anesthetics like ropivacaine can provide really good targeted pain relief. 4-acetaminophen is a good baseline.
What about opioids?
We try to minimize opioids if possible due to respiratory risks. Interestingly, some studies have looked at ketamine infiltration into the surgical site or even low-dose 5-E ketamine. Yeah, it's shown some good results in reducing opioid requirements, improving pain scores at 24 hours, decreasing sleep disturbance, and maybe even reducing issues with swallowing dysphagia post-op.
Interesting option.
And don't forget dexamethasone, a steroid. It's useful not just for pain, but also for reducing postoperative airway swelling, distress, and fever. The overarching goal is robust, long-acting pain relief using multiple methods, multimodal analgesia, while minimizing the risks specific to these patients, like respiratory depression or airway obstruction.
Okay, so wrapping this all up, after this deep dive, what does this really mean for you listening in the future or practicing plastic surgeons navigating this complex world of non-syndromic cleft palate? What are the big takeaways?
I think it means continually evaluating your own results,
Okay.
honestly. Understanding the subtle nuances, the indications, the trade-offs of each technique we discussed, and fully, truly integrating that multidisciplinary team approach. You can't do this alone. While specific techniques, like maybe the two-flap palatoplasty with really careful muscle reconstruction, show promising long-term speech outcomes in experienced hands, the real art of cleft surgery is still in tailoring the approach to each unique patient, meticulously balancing speech, growth, and minimizing those complications. Your role isn't just the technical repair, it's holistic patient management through what is often a complex lifelong journey for them and their families.
It's absolutely clear that meticulous surgical technique, combined with that ongoing research, staying updated, and proactive team collaboration, is just crucial for optimizing outcomes and really improving the quality of life for these children.
And, this raises maybe a final important question for all of us in the field to think about. Beyond just achieving technically successful repairs, how can we as a community get better at standardizing our long-term outcome measures?
Across different centers.
Exactly. Standardizing how we measure everything: speech, hearing, psychosocial well-being, facial growth, so we can truly compare different techniques, different timing protocols across institutions. That's how we'll ultimately optimize the holistic quality of life for every single child born with a cleft palate. Something for all of you to maybe mull over as you continue your journey in this incredibly rewarding and constantly evolving field.